Okay, thank you. I'm Dr. Vikas Agarwal. I'm cardiologist in City of Varanasi, and my clinic is Anandi Heart Clinic. And the today evening we have two discussion about the role of inclisiran and the role of inclisiran in the Indian patients. And before going to the inclisiran, some aspects on the lipid management. Thank you again. And starting with the questions. Yeah. So what are the optimal and safe target for LDL cholesterol level for high risk ASCVD patients? And how low can we go lowering LDL cholesterol with and mortality benefit? The answer I am discussing in the later, but again, what are the optimal and safe targets? The much lower is much better. Like in the high risk ASCVD patients, in every ASCVD patients, we have to low down the LDL cholesterol according to the Indian guidelines less than 50. If there is a further very high risk like extreme category A, we can go up to 30. In extreme category B, no doubt always less than 30. And in extreme category C, where is the recurrent ACS HEV is still after LDL with less than 30, we can go up to 10 to 15 or less than 20. How low can we go? I have cleared it. And lowering LDL cholesterol with mortality benefit, no doubt, there is a higher the lower number and there is a higher is the mortality benefit. Indians have a high CV risk and experience earlier CV events in the different program. Elevated LDL cholesterols are crucial due to their strong and always linear association with coronary heart disease and other ASCVD factors like the stroke events, cerebrovascular events, and peripheral artery disease event. And from the CTT analysis, each 1 millimole per liter, this is equivalent to 39 milligram per deciliter, decrease in LDL cholesterol is associated with a 21% reduction in the major cardiovascular event. At the same time, each 1 millimole reduction or decrease in non-HDL cholesterol is also associated with a 20 to 21% reduction in the major cardiovascular event. So picture here is this, either LDL, either non-HDL. The both pictures in the current scenario is a good option because LDL is a primary target and non-HDL is a co-primary target. If you look at these pictures, they have commented both on the primary prevention and the secondary prevention trials. If you look at the timeline trends, they are the linearly associated with the event versus the cholesterol level. So higher you achieve the cholesterol level, higher the event reductions, both in the primary and the secondary prevention trial. The latest guideline recommend to strike early or very early, strike strong or very strong, and strike for the longer period. Lower is better. If we talk about the different other guidelines, 23 ESC guidelines, where they have recommended for the ASCVD patients or high risk patients through less than 55. And in patients with a second CV event within the 2 year, an LDL cholesterol goal should be less than 40. 2022 ACC expert, they have the dual targets. One target is LDL cholesterol reduction for the ASCVD patient should be less than 50%, and LDL cholesterol reductions from the baseline is more than 50%. 2023 Lipid Association India by Dr. Raman Puri, they have commented very high CV risk in which ASCVD patients, LDL cholesterol less than 50. Extreme CV risk category A, LDL cholesterol less than 50 recommended, and LDL cholesterol less than 30 is optimal, in which they are also not only the ASCVD patients, they have commented in the category A, if there is a CAC scores, coronary artery scores is more than 300, you should maintain the LDL cholesterols less than 50 or less than 30. Extreme CV risk category, when there is a multiple pictures along with the ASCVD, there are other features of the high CV risk. So here you have to maintain LDL cholesterol less than 30, and extreme category C, where the ACS event is recurrent, in that conditions where still LDL is very low, less than 30. In that condition, you have to maintain LDL cholesterol up to 10 to 15. And this data came from the Odyssey program and the Fourier programs. A secondary analysis from the Fourier trials, about 25,000, show cardiovascular benefit with further lowering of LDL cholesterol level with no any safety concern even when the LDL cholesterol is below 10. And the safety events achieved by with LDL cholesterol over a median of 2.2 years. If you look the all the data, serious adverse event leading to the withdrawal, enzyme elevations like the AST, NALT, SGOT, SGPT, CK elevations, neurocognitive impairment, new onset diabetes, cataract related symptoms, new or worsening events, or non-severe death. In every terms, there is no any significant safety concerns related to when LDL cholesterol is significantly reduced. What is the approved indication of the inclisiran and where does inclisiran fit into the dyslipidemia management? First thing, what is the inclisiran? Inclisiran is the first in class siRNA therapy to lower LDL cholesterol level. siRNA is specifically work. This inclisiran is specifically work in the liver, mimics the body's process of the RNA interference, which is restricted to the cytoplasm, and this is conjugated with GalNAc for the specific uptake by hepatocytes, by which there is a low likelihood of the off-target binding. Inclisiran plasma levels declines within 24 hours and are undetectable within 48 hours. This prevents production of the target proteins, and greater hepatic uptake of the conjugated or circulating LDL cholesterols, and the reduction in LDL cholesterols in the bloodstream was seen. Okay, Indian approval with indications. Inclisiran is indicated in adult with primary hypercholesterolemia, in which heterozygous familial hypercholesterolemia and non-familial hypercholesterolemia is along with statin along with diet. They have not commented here is the homozygous. So they have commented heterozygous familial hypercholesterolemia based on the Orion 9 program, and the other non-familial hypercholesterolemia like in the ASCVD patients with the dyslipidemia. This is also called mixed dyslipidemia on the basis of the Orion 10 and Orion 11 program. In combination with a statin or statin with other lipid lowering therapy, like in the CSI guidelines or the LAI guidelines, they have focused that statin, if goal is not achieved, followed by the ezetimibe. If goal is not achieved, further you can add either bempedoic acid or you can directly start with the inclisiran or PCSK9 inhibitors. So alone or in combination with, and sometimes when the statins is not tolerated, like in the clear outcome programs where bempedoic acid along with ezetimibe was given, and in that conditions, if goal is not achieved, you can give inclisiran after that drug. So alone or in combination with other lipid lowering therapies in patients who are statin intolerant or for whom a statin is contraindicated. Generally, contraindication to statin is a very rare in the stage or very high stage of the liver disease, sometimes pregnancy. This is the issues are there. Which kind of patients benefit from this therapy? Inclisiran is useful in high CV risks individuals with atherosclerotic cardiovascular disease whose high LDL cholesterol levels remain inadequately controlled with the standard high-dose lipid-lowering therapies such as statin, ezetimibe, and bempedoic acids. And it is also useful in the treatment of the heterozygous familial hypercholesterolemia. What is the recommended dose? The recommended dose is 284 mg of inclisiran administered subcutaneous single injections in the hospital settings, then at the 3-month and then followed by every 6 monthly. This is the formula for injections. Solution is 1.5 ml where 300 mg inclisiran sodium was taken, water as the diluent. sodium hydroxide and phosphoric acid for the maintenance of the pH and store at room temperature. Dose regimes: initial dose, subcutaneous, hospital settings, second dose after 3 months, and after that 6 monthly for the long-term management. Under clinical investigations in Orion development programs to determine efficacy, safety, and tolerability, we have the data from the Orion 1, 2, 3. Initial programs Orion 1, and this 2 and 3 is the phase 2 programs. And after that, Orion 9, 10, 11 is a phase 3 program. Administration: subcutaneous injections in the abdomen by healthcare professions. Doses and administrations: I have discussed routine doses. If there is a missed doses, if a planned dosage is missed by less than 3 months, inclisiran should be administered and dose continued according to the patient's original schedule. If a planned dose is missed by more than 3 months, a new dosing schedule should be started. And inclisiran should be administered initially again at 3 months and every 6 monthly. Treatment transitions: if patients already on the PCSK9 inhibitors, monoclonal antibody PCSK9 inhibitors, inclisiran can be administered immediately after the last doses of the monoclonal antibody. To maintain the LDL cholesterol lowering, it is recommended that inclisiran is administered within the 2 weeks after the last dose of the monoclonal antibody PCSK9 inhibitors. Which patient suitable for inclisiran according to the global and national guideline recommendations? If patient presented with ACS, starting with the high doses of statins plus minus agitamide, if goal is achieved within a 4 weeks, then no need for the inclisiran. If goal is not achieved, then you can add bempedoic acid, wait for 4 weeks further. If again the goal is not achieved, here you can add inclisiran for maintaining the LDL cholesterol less than 50. The CSI guideline recommend that in patients with ACS, if LDL target is less than 55 is not achieved with the high intensity statin, azitimide, bempedoic acid, then another non-statin drug, PCSK9 inhibitors or inclisiran can be administered. In the different populations, heterozygous patients, secondary preventions, the pattern is same. After statin, if goal is not achieved, azitimide. If goal is not achieved, you can directly shift to the inclisiran or monoclonal antibody. Some doctors can prescribe bempedoic acid before inclisiran, but always it is not necessary. There's one data, Victorian initiative data, where after statin, you can directly start with the inclisirans to maintain LDL below target level. ACC expert guidelines is also the recommendations is clear in the case of different guidelines. In the case of ASCVD, the guideline very strict to maintain the LDL cholesterol to less than 55 or less than 50. There is a dual target here. First, to maintain the LDL cholesterol less than 55 and to maintain the LDL cholesterols more than 50% reductions from the baseline. And statin, although it is sufficient to maintain the LDL cholesterol up to 50% reductions, but every time it is not possible, then and sometimes patients not tolerated these high doses of statin. So in that conditions, you can add azitimides. The role of azitimide is about 10 to 15%, bempedoic acid further 10 to 15%, but still some populations cannot maintain the goal below 50-55. So that populations, that persons, that patients should be required inclisiran as early as possible to maintain the goal. Clinical insights from the phase 3 trials. We have the data from the main Orion 9, Orion 10 and Orion 11. Orion 9, basically the heterozygous patients from the United States, Canada, Europe and South Africa. And the Orion 10 is ASCVD patients, the United States. Orion 11 is ASCVD and high risk pictures equivalent to ASCVD patients. They are not that, they are the primary cohort patients. Orion 10 is only secondary cohort. Orion 9 is a purely heterozygous familial hypercholesterolemia, and Orion 11 both the primary cohort and the secondary cohort patients, and the patients population from the Europe and South Africa. And all the data is very complete. and up to within a 540 days, there is about 50% sustained LDL cholesterol reductions was seen, and between group differences between the 5-10 days, there is a 50% LDL cholesterol was achieved. 68% patient achieved goal below 70 and 52% achieved the goal below 50%. Increase in Asian data from the Asian patients, placebo adjusted mean percentage reduction in LDL cholesterol from baseline with the increase was 57.2, and the ratio of LPA to baseline levels of approximately 41% lower than the placebo by a day 330. If you look data, the global data of the LPA levels, which is about the 30%, but in the Asian population, the data is much sound about 40% reduction from the baseline. If you look at the other data, like the total cholesterol, which is minus 33.6, ApoB is minus 44.8. Because now the concept is changes due to the metabolic disease, due to the high burden of diabetes, due to the high burden of NASH, ApoB containing lipid particles should be reduced, should be primary target. So maybe in the near future, ApoB is a co-primary target. So here in the inclusion about ApoB is about 44.8% reductions. Non-HDL is also good pictures, 47.4, and other things LPA about 20%, HDL is about 7.5% in the plus manner. Inclisiran was generally well tolerated with the safety profile similar to the placebo apart from the injection site reactions, and the treatment emergent adverse reactions and serious adverse reactions generally similar between the placebo group. And the more participants experience, there's the injection site reactions up to the 5%, compared to the 0.7% in the placebo group, and this 5% is a mild to moderate, and this is a only transient, no any significant or any other medications are required for management. Long-term safety data, yes. If you look the data from the Orion 3, 9, 10, 11, and further there is a extended level data. This is Orion 8 data, which is an open label extension of the Orion 3, 9, 10, 11, in which 3,274 patients assessed long-term efficacy and safety of twice yearly inclisiran in patients with a high cardiovascular risk and elevated LDL cholesterol, showed inclisiran could reduce LDL cholesterol in the long term while being well tolerated. So there's about 3,000 patients up to 7-year exposure, and the data and the well tolerated. Inclisiran act in the cytoplasm of hepatocyte and not in the nucleus. So there is no risk of any carcinogenicity and immunogenicities. About result from the Orion 8, 82.7% of the patient enrolled had been ASCVD, and 113 is the baseline LDL cholesterol. 78.4 patients achieved their goal. 90% patient achieved their global lipid goal at any visits. On average, LDL cholesterol was reduced by approximately 50% at the end of the study, and the overall median exposure was 2.6 years, and the total inclisiran exposure was more than 8,000 patients here. The safety profile of inclisiran in Orion 8 was consistent with the previous studies, and reactions at the injection site is about close to 6% compared with the 8.2% in the inclisiran above the pooled analysis of the 9, 10, 11. So every time these injection site reactions with the 6 to 8%, and which is only mild to moderate. Inclisiran cardiovascular data, main cardiovascular data is not published. That is the Orion 4 and Victorian 2P, which is the CVOT data, and the completion date is anticipated in 26 and 27. But still, with the exploratory analysis of the Orion 9, 10, 11, we have achieved 26% significant reduction of the MACE compared to the placebo. And this Mendelian randomization studies with the 20 million persons year of follow-up proven there is a dose-dependent log linear association between the absolute magnitude of exposure of the vasculature to the LDL cholesterol and the risk of ASCVD. There's a huge, this is the meta-analysis from the CTT analysis, a 1 millimole reduction of the LDL cholesterol means 39 milligram per day per deciliter LDL cholesterol reduction is associated with a 21% reduction of the MACE. So this is a huge data, and there is a linear association in every vasculature arm. Thank you.